All right. Well, good evening, everyone. I'm Paul Sraja, cardiologist in Minneapolis, and I'd like to welcome you all to this edition of Ultimate Structural Heart Cases. This is a webinar that we do regularly throughout the year. We often title this the Imager and the Interventionist, and I cannot think of two better imagers to help us kick off this webinar for this fall that will be continued into the next meeting next summer. So this is a CME accredited activity with learning objectives, as one can see here. There's a possibility to claim one category credit should you choose to do so, and that credit is free just by participating in this activity. I'm very lucky to have such great friends and colleagues who are willing to take the time out to do these webinars with us. Tonight, we are joined by Dr. Abdallah El-Sabag, Dr. Nadira Hamid, and Dr. Lucy Safi. And it will be wonderful to describe some recent experiences. Here's some disclosures for tonight's activity. And we'd like to thank Abbott, Medtronic, and Shockwave for sponsoring this. It's been really wonderful to have the ability to reach and describe these experiences as part of what we do. And if you're interested in claiming that credit here, you can go to the website at the end of this webinar and complete the evaluation and request form, and you can then download or print your credit statement. And lastly, we are going back to Denver next year. We had a very successful 2023, I think one of the best ever in Austin. We'll be heading back to Denver next July 18th to the 20th at the Hyatt Regency, and we look forward to having you all there. This year, we will have additional 2 tracks. We usually have coronary, peripheral, and structural. We will also have interventional heart failure and an aortic track in addition to that. So 5 tracks for all the different people who might be interested in attending the Operators Enclave. This is our website where you can find enduring materials such as tonight's broadcast, which is recorded and can be reviewed and downloaded again. So with that, I'd like to turn it over to our first presenter, Dr. Lucy Safi, an outstanding imager. She has been part of the CVI family since the very first year in 2017. She has not missed a year since, and year after year, she's come and just really shown us amazing cases at our meeting and just been an incredible faculty member. So I'm very excited to have her kick it off tonight. She's an imager out at Mount Sinai, if you're not aware of her experience and what she does. And Lucy, without further introduction, thank you so much.
Thank you so much, Paul. And I want to thank CVI for having me. So we're going to go ahead and get started. Let me just kind of hide some things. All right. Can you see my screen?
Yes, it looks great.
Excellent. All right. So thank you so much. I'm going to be starting it off with an ultimate structural heart case. And my case is an 85-year-old man, and he has a history of symptomatic tricuspid regurgitation and was referred to see us at Mount Sinai. He has coronary artery disease and severe mitral regurgitation, in which he underwent a CABG and a mitral valve repair in 2006. He came back with a VF arrest in 2015 and underwent a sub-Q ICD placement at that time, and also has a history of heart failure, hypertension, hyperlipidemia. He's been suffering with heart failure related to right heart disease from his tricuspid regurgitation for some time. He is fairly active, and this was definitely interfering with the quality of his life. He followed with heart failure here, was optimized the best that they could, but continued to have recurrent admissions for decompensation from his right heart disease. And we tried to get him enrolled in the TriClip or for the Triluminate trial. However, he kept having recurrent admissions and wasn't stable enough to be fully enrolled. So I ended up having an off-label TriClip. And so here's his TE imaging, and you can see that he does have his annular ring there in the mitral position. It's working fine, but his right heart significantly dilated. these images were incredibly challenging, not just because he had an annular ring in his mitral position, but also the location of his esophagus in the chest was just not directly behind the heart. And so there was a lot of lateral rotation, a lot of extension, trying to get these pictures. And even with all these advanced maneuvers, overall, it was just technically difficult. And extremely challenging. The mid-esophageal views were extremely hard. And so the good news is, though, his deep esophageal views and his transgastric views were much better. As you can see here, this stresses the importance of really checking these views that sometimes we forget, but for a tricuspid evaluation, it's extremely important. So with these views, we were able to go ahead and build off our NPRs and really assess the tricuspid valve better. And we determined that, we would most likely be able to go ahead and offer him that off-label TriClip based on these images. So we took him to the lab, and, the day of the procedure with him intubated on his back, his mid-esophageal views aren't much better. So they're still technically challenging. You can use them to steer the guide in, and you can see us testing the clip in the mid-esophageal view, but really after that, the mid-esophageal view was essentially worthless and not really used. We pretty much did the rest of the case from those off-axis views or from the transgastric view, and then also ICE. Here you can see some of the NPRs that we used. This was an extremely challenging case. Everything was off-axis, and it was definitely difficult. So our plan was to go ahead and start clipping from the A and the S, and then zip it. So we'll start in the anterior and the septal leaflets, and then keep clipping in order to reduce this torrential TR by at least 2 grades. So that was the pre-specified reduction that we were aiming for. So we went ahead and, just for time's sake, we zipped it. So 1, 2, 3 clips were placed. ICE was used. Unfortunately, they didn't transfer, so I don't have those to share with you today. But we did use Siemens ICE for this case, and it was definitely helpful to go between the Siemens ICE and also these transgastric views. So all in all, after 3 clips, his TR was significantly reduced. Definitely, I think, in my opinion, more than 2 grades reduction. You can see here at the bottom, transthoracic imaging afterwards the next day, pretty good reduction. He was discharged home. He was feeling well, was swimming twice a week. And, the quality of his life was really back to normal for this 85-year-old man. So that's not my ultimate case, because, there has to be more. Tricuspids are hard, but 6 months later, unfortunately, he came back, and he had recurrent hospitalization for heart failure again. His legs started to swell again. It was harder for him to swim. And so we went ahead and did a redo TE on him, and his images were not much better. His TR was back to being significant, definitely increased. The quality was still subpar, and we couldn't really figure out what exactly happened to these clips. And so now what do we do? So we have this 85-year-old man who's non-surgical with right heart failure, recurrent hospitalization now. We already did 3 clips, and it was extremely challenging. So should we try to do a redo? Should we take him to the lab and maybe use a different ICE catheter, or, do we schedule the patient? So I could pause here. I would love to hear what everyone else would do, and then I can tell you what we did. But any thoughts so far from the rest of the panel?
Well, this is a great case, and one could easily see that that tricuspid valve really wasn't functional. It was more degenerative, and it's similar to what he had on the mitral side. You imagers, would you agree?
I mean, I would agree. I think, Nadira, what are your thoughts?
Yeah, no, thanks. That was a great case, Lucy. I mean, absolutely. I mean, it was a great result. I mean, you got down the TR reduction, and like what Paul mentioned, there was the degenerative component, not only on the right side and left side as well. And the question is, what happened to him, like what you said. And I think that will be the next step to figure out what went wrong. I guess whether the clips are still stable, are they doing its job? You want to check for SLDA, although it's 6 months, you would think, probably unlikely you would see something acute in 30 days, right, Paul?
Yeah.
But, or is it, the gaps become bigger in between the clips. So I think further imaging would be great. Whether I think the TE images that you shown are really challenging. So whether or not you bring him back into the cath lab and do a right heart study, intubate and do a TE and ICE at the same time, I think just to further investigate that and see what we can do about it, I think that'd be great. That would be what I would do, I would think.
I think
Yeah.
that the ICE has really just changed our tricuspid practice to a big degree. And I think it really has helped with the leaflet insertion. And you've seen things with the 4D ICE that we just really weren't appreciating when we did TE alone. And the degenerative nature of those leaflets can make it hard to make sure there's enough leaflet inside when you don't have enough good imaging quality. Abdullah, are you using 4D ICE in your tricuspid procedures?
Absolutely. Like you said, it really changed the way we do them. We initially used them to make sure that the leaflet insertion is adequate, but now it's gaining more and more emphasis on the procedure, different procedure steps as well. So especially with those challenging imaging cases, sometimes we're relying a little bit more on the 4D ICE on top of the leaflet insertion. So the other views.
All right, let's see what you found.
All right, so what we did, he's non-surgical, he really needed some help, so we took him back. And back on the table here, his TE images again were really limited. And so ICE is really the key, as mentioned by multiple people here. So what was the etiology? Let's take a look. And so we use the Phillips ICE, and just for the purposes of this presentation, I'm going to label them 1, 2, 3, and from anterior to posterior. And what we did was we can biplane through each clip to figure out if there's any loss of insertion or any kind of issue. So the first clip here, actually, although it doesn't look straight, it actually was fine. Insertion was good. It was well seated. Number 2, SLDA'd, and that was probably the etiology of the increase of the TR. It's interesting that it did, like Nadira said, a little bit later than expected, but it did. The third clip, the first case was just extremely challenging, and the third clip actually is attached to subcords. So it's not harming, but it's really not helping much for this patient. So we have an SLDA, we have a patient with severe TR again, or more than severe. And so what to do? We decided to go ahead and try to redo this clip and put another clip between 1 and 2. So that was our goal. And it's obviously challenging to do it and not dislodge anything. So we went ahead, it was pretty much all ICE guided. And so we lined up our planes on the clip and I tried to make it as big and clear as possible. But what you can see here is in this image, the septal leaflet is clearly inserted, and that we have insertion most likely of both leaflets in that view. And then we went ahead, dropped the grippers, and you can see a nice bounce in the top image here, and went ahead and closed it. Now we took our time because we didn't want to dislodge anything, and we wanted to make sure that we had insertion. It was extremely challenging to make sure that you have insertion and not being fooled, just because there's so much going on that right side with the other 3 clips already there. So after we closed, we checked with color. We had a pretty good reduction. So if you look from the clip and anterior, so the new clip and anterior, there's really not much TR left. So we got pretty much all the TR in this area. This was present even prior, and we thought about going after that later. But let's see, I think after we deployed it completely, on Fluoro, what you can see is this is the SLDA. Sorry, it looped funny. But after we went ahead and grasped it, you can see that it's much more stable with this clip and less motion. After deployment, same thing here on Fluoro. You can see that they're moving together. It's much more stable. And reassessment with color after complete deployment, we still had that one primary jet here, but everything from the new clip over was much reduced. And, you know, he's 85 years old. We felt that we had pretty good reduction at this point with this redo. And if he comes, you know, back to the hospital with a heart failure addition, maybe we'll tackle this one. But we really didn't want to do it in the same setting. We'd love to hear if everyone else would agree with that, but it was challenging. And then, you know, quantification of TR after clipping is hard, and then let alone 4 clips. You know, PISA is essentially not doable in these patients. I tried PISA, we tried vena contracta area. To really quantify, it's really hard to do so. And so looking at transthoracic here, next day follow-up, you can see that pretty much in every view, it's very much reduced. It's just that one major jet left here, which, you know, we called moderate, but I would be interested to see what everyone else would think. It's purely eyeball assessment here, because there's no other way that I could figure out how to do it. So that's my ultimate case. It's a case of redo tri-clip, and I'd love to hear thoughts from the panel.
It's fantastic, Lucy. I mean, congratulations. And so, you know that type of TR reduction we know is meaningful for the trial and the trial results. And the average KCCQ when there's 2-grade reduction is +15. So we know that it's meaningful. Very difficult on the posterior septal clip, you know, with that cords. I think when it's hard to see, there's a lot of dense cord in those areas that could pull things out. Be interested to think what Nadira thinks about the quantitation there. I mean, how do you look at severity? I mean, you got like garden hoses being shut off in multiple different directions. I have no idea how to look at that.
Great. I mean, quantification, I mean, you think after a mitral clip is difficult, let alone a tricuspid. So, you know, you have multiple clips there, as you can see by the images by Lucy, beautiful images. And so there's multiple jets. And I think the 3D vena contracta area, obviously you have to measure each and every one of them, and then across the systolic cycle, and then you have to average them and then just add them up, each of it. I could see at least 4 jets. So it's painful, but I think certainly doable. I think that would be the gold standard in the TEE when you're in there. Now, transthoracic, like you said, it's really hard visually, obviously, but remember that when you assess the jet, because you can imagine like a garden hose, right? You put your thumb over it, it's like a little spray. So, you know, like you mentioned, just be very careful instead of the jet area. It's like a little spray. So we tend to overestimate, but moderate seems about right. So multiple parametrics, your qualitative, you know, your VC width, and then PISA, you know, we do that in the study. Quantitation, it's obviously inaccurate. You can tend to overestimate it, but certainly that's one of the ways. And obviously 3D vena contracta area. Transthoracic is doable, but really hard and challenging. But when these patients' RV is big and enlarged, you can certainly get them. But it takes some time, and I believe practice makes perfect. So, but certainly all the quantitation that we can do. And then the other thing is the hepatic vein reversal. I'm sure there'll be some, you know, it's probably still there, but I think the reduction in the VTI showed that there's some improvement in the TR reduction as you've shown. But beautiful case, Lucy.
Thank you.
I noticed that your ice crystals or your angles were 45-45 for the grasping, which is, you know, we know is so important, you know, to change because of the rectangular arrangement of the elements. You went 45-45 and you got a beautiful view. And when I see the ice catheter and the tricuspid valve so well lined up, that tells me that the T is even really worse because it tells you that the heart's really horizontal, you know, and that's probably why your imaging was really hard with TE. So yeah. So Abdullah, I have one quick question for you. Left groin or right groin? You know, when you're doing these, because I don't know if Lucy, you remember if you went left groin or right groin. Do you have a preference when you go left groin or right groin when you're doing off-label clips?
So we don't have access to the TriClip, the dedicated system. So if we're using the off-label MitraClip, we're doing that via the left femoral. It's so much easier, it stands it up better. Yeah. But if we're also sometimes using off-label Pascal, that we can use both. So we've been using it on the right side for ease of just operation.
So that's interesting. So Pascal doesn't matter right versus left, but with off-label mitral, you tend to go from the left.
Off-label mitral for sure, the left.
Yeah.
It's just so much easier. But Pascal is a little bit has more maneuverability. The 3-catheter system makes it a little bit more facile to maneuver. So we've been using it from the right side. Haven't tried it from the left, but I guess it'll work from either.
I've been doing it from the left. I've even done the tri-clip from the left, and I think there's a slight preference for that as well, because the ICE catheter can go on the right, and ergonomically it's easier to not have to reach through the device to get to the ICE catheter. So, but anyway, we probably should move on. Lucy, thanks so much. Please, of course, chime in as part of the panel here. Abdullah, you want to show your case?
All right, let's share the screen here. All right, can everyone see the screen well, or switch or do I switch? Okay, good, perfect. Okay, so here the leaflet. I'll be presenting a little bit of a challenging case here, and I really appreciate everyone's help in. And it's a 74-year-old gentleman, a mitral valve repair in 2019. It seems like it's the day of the rings today. So 34 Edwards Physio 2 ring, admitted he's in the hospital with acute heart failure. TTE followed by a TEE shows the following. Recurrence of the P2 flail. You can see the ring here on 3D with a severe mitral valve regurgitation. More images. Here's the explained view with and without color. You can see the flail on both sides and the starting mean gradient of about 3.5 millimeters of mercury. So I wanted to open it up to the panel for discussion to see what everyone's thoughts would be in terms of what to do here. You're still muted, Paul.
Sorry, I was going to say fantastic. I love this. I love these cases. So let's start with Lucy. What do you think?
I mean, so these cases are always super exciting and super fun. As a, from the ring perspective, if they're shadowing, it's hard to see, but you can actually see these leaflets pretty well. And your gradient is acceptable. After you clip these, the gradient can go up. I think measuring a valve area, if you can, is super important, because I find that you get this false sense of security with just looking at a valve gradient. But with the rings, I feel like the gradient does go up much higher. But I do think it's clippable, assuming that the valve area is appropriate.
Nadira, you think that gradient is MR or MS?
My gut feeling was the MR. I would, like Lucy said, you know me, I would love to do that mitral valve area at a leaflet tip on 3D because you can see in the view on the left-hand side where the biplane imaging, that's where probably one clip may actually, if that's the predominant jet, Abdullah, am I right? I think that's where the predominant jet, and I think if you just put one clip there, you might actually, get away with a reasonable gradient, I think, with a valve area too.
Abdullah, what was the size of the ring again?
A 34 physio.
Oh, so it's actually a big, pretty good sized ring. So my feelings, I love these because the leaflets, if they haven't resected the leaflets and they've left them behind, they've kind of put it right there for you to grab. And so to me, the governing decision point is about the stenosis. And if the ring is small, then it makes it harder. But if the gradient here is an MR gradient, which it kind of looks like it is, it's kind of got a short pressure half time, then it may actually, I've had cases where the gradient actually goes down. But it all comes down to what we're starting with valve area.
All right, those are all excellent points.
I have a request from the audience. Can you turn off presenter mode so they can see this?
Sorry.
Please, thank you.
How about that?
There we go. Thank you very much.
Beautiful.
We switched to Teams, so I'm deconditioned on Zoom, so that's perfect. Okay, back to the case. So, like, to summarize all the points that you just mentioned, when we're deciding tier versus valve and ring for these recurrent MRs, there are four things that I usually look at when making these decisions. The first one is, can tier be done or achieved using one clip? To Lucy's point, the risk of MS is there. Yeah, again, we have a false sense of security, but when we put that first clip in and the gradient usually shoots up, that's not fun. So if it can be achieved with one clip, favors tier. If not, then favors valve and ring. The second thing is there leaflet paucity? Like Paul mentioned, the surgeons can sometimes cut a lot of the posterior leaflet, making it unfavorable for tier. Third thing, what are the risks of valve and ring itself? There's a lot of risks that can be with this procedure. So we look at mainly the periprosthetic regurgitation risk, Embry angle, even the type of ring. So the Physio 2 on the Valve and Valve app, the 34 actually states that it can be done, but it comes at an increased risk of PVL. And it's particularly because of its saddle shape. So when we deploy the valve inside of it, part of it will be anchored, but on the nadir of it, it may be at a point where one of the cells is uncovered with a skirt, causing a perivalvular leak. So that's a unique thing too for the physio, given its saddle shape. Obviously, we know all the LVOT obstruction predictors: the neo LVOT, the anterior leaflet length on the TEE, and then the skirt neo LVOT, which wasn't a big concern in this case. Lastly, is there ring dehiscence? Because if there is, then it does not favor valve and ring. So we decided the patient is in the hospital. He's sick. It'll be quicker. It looks like a focal flail, like Nadira mentioned. We can get away perhaps with one clip. And then the physio 34 millimeter on the valve and valve app is iffy. So we decided, why not? Let's just try to clip and ring. So here's the NPR. We decided to go with an NTW because of the area measured, and so we lined it up over the flail, and then went across, ensured the leaflet insertion. Imaging can be tricky in these cases because of the shadowing, but here we ensured leaflet insertion, a good tissue bridge, and then when we closed on color, was a decent reduction. Again, perfection is the enemy of good in these cases. But when we moved the cursor just lateral to check, there's just still that little small area of prolapse with that little jet.
Is there still a little flail there? Is it a little flail segment?
Perhaps a little flail, but the flail was tucked in for the most part, but there may be still a little one right here. So I'll give you some more information. Oh, go back. So the gradient went up from 3.5 to 5 millimeters of mercury with an elevation in the A wave, so kind of starting to get some mitral stenosis physiology here. Pulmonary veins improved dramatically, and then that was the V wave reduced. Again, the slope of the V wave was less, again, also suggesting perhaps a start of a mitral stenotic physiology, but overall an improvement. So we took it. We decided, let's just accept the result. And again, the purpose was to get the patient out of the woods, and he was very sick in the hospital. So we were left with that little jet, the little jet now. So we celebrated. Patient was discharged, and 3 months later, we got a portal message. Patient calling, stating that he's feeling worsening shortness of breath.
Oh no!
And then an echo showed the following: TEE, no SLD. However, that little jet has now become a bigger jet with and large P's that's coming across it and the lateral to the deployed clip. So what do we do now? I open it up to discussion.
So you could lacerate it and do a valve and ring.
Would you attempt another clip?
It depends on what kind of gradient there is. But
it was still about 5, yeah.
Still about 5. I mean, I certainly don't think you'd lose anything by trying. You could try, and if it's high, then you could take it off, which is reasonable. That might be a more logical step than going down the limb, lampooning it or lacerating it and putting in a valve and ring.
Absolutely.
If he was
Nadira?
stable, you could also just send him back to surgery.
He was not. He was not a surgical candidate.
Okay.
We definitely had that discussion. And
Not
all
a
right,
surgical candidate at Mayo. He must have been really frail.
yeah, he was really frail. So he was definitely decompensated and frail. So we had a multidisciplinary discussion, and like you mentioned, Paul, we elected to do an elastic clip plus a valve and ring. So for those who are not familiar with elastic clip, this is an electrosurgical technique where a wire basically is electrocuted around the anterior leaflet to free up the clip, and followed by TMVR and tucking that clip posteriorly. So it doesn't go into the LVOT. So the planning, again, we didn't obtain a CT scan before we did the clip, which is a lesson to me. I think any decision, and when there's a ring involved, we should have a CT scan, just because we never know what would happen down the road. But luckily, favorable Emery angle, favorable neo-LVOT, and a favorable skirt neo-LVOT. And then the anterior leaflet was not long on TEE. More to come on that point, though. So we proceeded, balloon pump in place, septostomy up front, and then 2 steerable sheaths, through them 2 JR4 guides, and then a snare, and then the Astato wire and a piggyback. We snared it, formed the flying V. Shout out to all the imagers, really. Like, this is one of the points where we look at our left and say, I'm so grateful you're here. And Apraj Reddy, our imager, was imaging for us. So we want to make sure the catheters are both on both sides of the clip, and that they're biased anteriorly, again, because the laceration needs to be anteriorly. You can see here beautiful 3D images, and on 2D even, here's the aortic valve, so anteriorly, and then here's both catheters and the clip in between. So also fluoroscopy and biplane can be used. So 70 watts of cutting. It is you can feel that there's more tissue in, so it feels a little bit more tense compared to just a lampoon, and then a good pull, and that's when the posterior leaflet is free with torrential MR. Balloon pump has to be on here, especially with this patient who came in with poor reserve because he's admitted with acute heart failure. So he really needed that balloon pump. And then following that, slow, deliberate movement, making sure that the frame is not catching onto the clip, because most of these Elasta clips, the reported ones at least, were done with Tendyne. But this is we did with a Sapien, which is a shorter frame, and so there's a potential of interaction with the clip. So you can see here a good deployment. Now, one thing that, again, I learned from this case that I wanted to share is we always focus on anterior leaflet overhang, but with these short frames, if there's a long posterior leaflet and now there's a clip on top of it, that clip, the edge of the frame may serve as a hinge point and may lead to a leaflet overhang and interaction with the deployed valve leaflets. But luckily, it didn't happen in this case. That's where the CT scan before the initial procedure helps as well. So no LVOT obstruction, mild periprosthetic regurgitation. So patient did fine and was discharged after that. So in summary, MR and failed surgical ring is a therapeutic challenge. Tailored approach for decisions on TEER versus valve and ring. But at least trying TEER first does not negate valve and ring, especially that it is feasible using balloon expandable transcatheter heart valve using ElastaClip concomitantly. Thank you.
It's fantastic, Abdullah. How did you, since you are cutting the anterior leaflet, how do you measure or take into account the LVOT, neo-LVOT measurements? I mean, do you just essentially go by the skirt neo-LVOT? I mean, because I'm just trying to understand skirt versus regular neo-LVOT. How do you factor that in when you're going to be lacerating it?
I really this is a hard one. Obviously, I don't know. I don't know if anyone knows the true answer to that. But he had a very wide LVOT and skirt neo LVT, I was not as concerned because we are taking part of the anterior leaflet as well.
Yes.
How much of it does it also improve the risk of LVOT obstruction? I'm not sure, but starting at baseline, he did not have any. The LVOT and the neo LVT were wide, and so that was in our favor. But if
Yeah.
it was narrow, then what? I don't know the answer to that, to be honest.
And do you
What do you
use
think?
do you have a preference for the Sapien Ultra, just because of the taller skirt when you're doing these? Was this an S3 or an Ultra case?
It was an ultra case.
Ultra case, yeah. That extra a few millimeters of skirt really can make a difference there.
Correct. No, absolutely. Especially with the saddle shaped ring, and then an uncovered area of skirt can lead to
Yeah.
PVL. So
And what do you tell people about the embolization risk? But we've had a number of these, but I'm not quite sure what to tell them. And what's different is that, you know, with Tendyne, the ones that have been reported, the clips kind of get trapped because the frame's so large. But here, the clip is kind of overhanging and dangling in the LV. So what do you tell them?
I really tell them this is not too common of a procedure, that it is an unknown, but it's kind of the only option in this situation, so to speak. And access to tendon is not that common, but I will mention that it has been reported that I know Jamie McCabe has removed the clip fully using a double. So he basically did the same flying V, put it back in, and then lacerated posteriorly while having an Ono device with a snare through it. But the thing about these procedures is when we tear the anterior leaflet, the patients become shaky. I mean, and then we just have to move quick. And so that especially in this patient, that happened. And so, but that's one option, at least for those with long posterior leaflets.
Right. Fantastic. Lucy, Nadira, any comments before we move on?
Just that was an amazing case with really, really great imaging. So congratulations.
Thank you.
Yes, the imaging was outstanding. That is true.
It really was. No,
Yes, it's a great case, and thanks for the shout out to your imager. Great
thank
work.
you. Always.
Great team.
Fantastic. All right, next up, my colleague, Dr. Nadira Hamid. Nadira, do you want to take it away here?
Thank you very much, Paul. Let me just share my screen. And can you see my screen?
Perfect.
Okay, sorry, I forgot to use the deck slides. So, and I thought I would like to share a case. I thought it was simple enough, but it reverted me back to being a good old fashioned. Is it a drink or being a good old fashioned imager? So I thought I named this title as a good old fashioned to keep you guys intrigued. These are my disclosures. And so we start with a 56-year-old gentleman. He had, multiple PCIs over the years, and obviously his EF has been affected. Ischemic cardiomyopathy with an EF of 30-35%. He's been on optimal medical therapy, thanks to our heart failure colleagues, with all the goodies, as I call it, the Entresto, Farxiga, beta blockers, spironolactone, and also an ICD. But despite that, he had recurrent heart failure hospitalization. And so his echo certainly showed significant functional mitral regurgitation over the years, and that has led him to his recurrent heart failure hospitalization. And obviously workup for that, for both transthoracic and TEE here, as you can see, the baseline transesophageal echo, this was done at an outside hospital. As most of us get referrals from patients, you can see dilated LV. His EF is certainly reduced. And these are the imagers that you can see with significant mitral regurgitation. And so we felt that certainly with his symptoms, it would be ideal for a mitral clip procedure. And so on that day, I was actually rounding upstairs, and these were the images obtained by my colleague, and you can see the EF transgastric. But going up to the mid-esophageal view, you can see hugely severely dilated LV. You can see the imaging very challenging. You think that there's no atrium, but actually his atrium is actually really large, but you can see color Doppler at the long axis view. Certainly adequate posterior leaflet for a mitral clip. And so I was called down to try and help improve the imaging. But here, I'm going to stop here and ask the faculty, would you still proceed with this kind of imaging? You know, here you can see the posterior leaflet. This is, would you still go ahead with a mitral clip procedure on the table? Would love to hear your thoughts. What would you do? This is as far as we could go. It was really challenging.
I feel like that's a leading question, and I'm just gonna say no.
So would you abort the case, or would, you know, is there anything?
Well, I mean, this is really hard because, you know, to get really good results, we need to see the leaflets in systole and diastole. And here it's just coming in and out, and it makes the grasping and the timing of the grasp really, really hard. And so I would say I would consider aborting, honestly.
Lucy and Abdullah, what are your thoughts of, you know?
Yeah, I mean, I think the patient is there already. Some of the other views were a little bit better than this one. So, you know, I think when you have these patients with really dilated ventricles and they essentially have like a left atrium that is more horizontal than in the AP direction, they get extremely difficult to image. You know, not only is it clipping going to be hard, but we haven't seen the septum, so I don't know how the transeptal is going to go, or if you're going to have enough height. You know, these are all these other complexities when you start to think of a tier. So obviously this clip, it's not going to be ideal to clip, but I wonder if in other images, or even maybe from the stomach, if you can do an NPR. I mean, this is where you start to get creative. To see if you can just get any other views that will show you both leaflets.
The stomach is yeah, that's 2006, 2010 maybe. I think that's a great idea.
There was an audience question of try transeptal ice.
Yeah,
That was my next point, is for the ice.
Yeah.
Abdullah, tell us about transeptal ice for mitral.
So it's very challenging. It's not like the tricuspid side. I've done it twice, and my back remembers these cases. So they can be long cases. So I do them separate transeptal puncture with the ice one higher than the mitral clip one, just so that we're always above it. Some issues with 4D ice. There's can be a lot of interference for some reason when I put them on the mitral side, because I usually have a TEE probe inside, and even when we shut off the TEE probe, there's some interference sometimes. But we can get most of the views to steer and grasp and align. So that may be an option in this situation. But I wouldn't, like Paul said, I wouldn't proceed with clipping without additional icing modality here.
We like ice. I think the challenge is the far field reach. You know, if the ice catheter is, you know, more than 5 or 6 centimeters from the valve, it makes seeing really hard. So sometimes we'll put in a Destino and try to get the ice catheter as close as possible, or take a very anterior transeptal puncture. And sometimes you can get there that way. But anyway, Nadira, why don't you show us what you did? Because I know this is not where it ends.
No. So at this point, I was in the cath lab, called down, you know, while seeing my patients upstairs. But so I said, let's go ahead. Let's do the transeptal. And so, you know, I think we can do it. So intraprocedurally, so this is a transeptal. You can see getting as posterior as you can on the left-hand side, and using 3D MPR as well on the right-hand side, measuring the transeptal height. I do that a lot, really aligning the planes and then orientating to the mitral valve annulus. And you can see here in the crosshair, the transeptal height is approximately 4 centimeters. And we took this puncture across, and then moving back, trying, you know, and then so as we cross over with the catheters and delivery. And what was interesting, I found at this same exact spot, and I was exactly thinking of obviously using the transgastric view, short axis, like what my first mentor actually taught me when I was a junior fellow in Singapore. And so, but what was interesting from this view, all I did was actually just clock my probe, and this is what I got. I got an exactly short axis of the mitral valve. And that's when I said, we can do this without ice. And so when I got this image, and this was very interesting case because I believe that his left ventricle was so enlarged that, you know, I didn't have to go to the transgastric view. I was right there at the transeptal. You can see on the left-hand side, and all I did was just rotate my probe, and I got a short axis from here. And you can see from here, what we then continued to do is exactly your bicommissural equivalent, exactly that, with the orthogonal view being your long axis. So exactly like how you do a mid-esophageal bicommissural view from your mid-esophageal view, and you're sweeping across from the medial to lateral. That's what I did, exactly that, to show Paul exactly where to do the target lesion, the target clip location. You can see on color Doppler, majority of the jet being central. This is a functional mitral regurgitation, but it's a seen across the commissures. And with this view as well, once you can do your quantitation. You know, as you all know, I love my quantitation. So we did a mitral valve, valve area from here, 3D MPR, 4.3 centimeters square. The 3D color Doppler you can see across the jet is severe at 45 centimeters square, measured across the systolic cycle. The mean gradient, I got it in the mid-esophageal because you can't get, you know, perpendicular, but it was 1 millimeter per mercury, and also got systolic flow reversal in one of the pulmonary veins. And you can see on the right-hand side, orientating the 3D MPR for alignment, which I'll show you as Paul crosses with we proceeded with the procedure. You can see from there, from the transeptal, and then all I did was clock to get this short axis. 3D MPR was really helpful. I think really a game changer for this. And what's the beauty about this is combining old school, our transgastric 2D and the 3D as well, and the multiplanar reconstructions to try and align and perpendicularity of the clip as well. So you can see during the procedure, as the images play here, you can see short axis on the bottom right, exactly as you get from your mid-esophageal views, orientating the clip. You can see he counterclockwise it to get right into A2P2. And then closing the clip, right, Paul, before you go down underneath the leaflets, as you can see on the right-hand side. We do a lot of this, I think, under 3D MPR, provided that your 2D imaging, I think it should be good to begin with. And once underneath the leaflets, I think you hear in numerous talks and speakers about gaining down. You can see on the left-hand side, as we gain down, what we saw that you can see the clip actually rotated a little bit. Sorry, rotated. So you just have to reorientate it. You can see right underneath the leaflets, and you can still remain in 3D MPR as well as your interventionist rotated, like what Paul did, just clock it again. And then, before clipping, what we like to do is then also, go back, revert to our 2D biplane imaging for grasping. And I think, if we get a very good 3D MPR, of course, I think you can still grasp it, but, I think we do have to understand the limitations of 3D MPR. And so we felt, I think with biplane imaging, as you can see the images, it's really, really off center here. Just going to go to the next slide here in terms of the leaflet grasping. Back to 2D, I think 2D, Paul has taught me this really, it was very clear in visualization of the leaflet. Sometimes you can see the leaflets being caught by the grippers, and sometimes you can't really see it well with 3D. So really, I think as imagers, I think we should be flexible, reverting back 2D and 3D, because we need to be sure, both us imagers and interventionists, to get that leaflet in to avoid that SLDA. And so here you can see he's a little bit off center. You can see the middle there. He just moves slightly to the center, and then proceeded with the leaflet grasping right here in our so-called transgastric view equivalent. And then clear visualization of the leaflets you can see in the clip arms as he closes it, the clip arms here, and confirming here beautifully, getting that butterfly, that tissue bridge, as you see in the mitral valve. At this point, I was very excited in a cath lab once he did this, to see this, that we managed to catch it really well. And, you know, what we obviously do normally, although the images are off, you know, do the same thing, confirm it before releasing, right? Check your valve area, check the mean gradient, you know, 2 at this point. Check the tissue bridge. So you can see on the 3D MPR on the right-hand side beautifully here. You can appreciate, I love this image on the right-hand side, the cords right next to the clip, that adequate tissue bridge, you know, before releasing this. And so, you know, once confirmed, and then obviously the final assessment here on the left-hand side, you know, ensuring that the clip remains stable. On the left-hand side, you can see beautifully the cords of the mitral valve, color Doppler, really trace MR, and the mitral valve residual valve area measured at 2.5 centimeters square. And, you know, really, I think we didn't need the ICE catheter for this, which I thought was, you know, we were lucky, Abdullah, to get away without it. You know, but really, I think, you know, like what Lucy presented and, you know, all of us on the faculty, I think 3D eyes and what Paul said, the 4D eyes as well, has really revolutionized, I think, the landscape, especially in the tricuspid with the case that Lucy showed. So we have 3 different vendors, Philips, GE, and Siemens. Very exciting times with the tricuspid, of course, with mitral and the left atrial appendage as well. And so here, I'd like to show you some images of eyes for the mitral, like what Abdullah said. You can do a transeptal, double transeptal. So you can see, you can get beautiful images, just like a TE. So courtesy of Philips, thank you. You can see color Doppler, you can do the 3D MPR, you can get 3D as well with the VR, and also, you know, love the true view here, like the tissue density of it. And this patient obviously had a successful mitral clip with just mild mitral regurgitation. And I think, you know, before I end, like, we'd like to show you another slide, which I thought for the future, thanks to Joao, one of my colleagues as well. I think, you know, predicting how these cases can be before we go into the cath lab. I think that would be really nice to see whether do we need eyes. Of course, TE, the screening T can give us a sense, but when the patient lie on their back, I think it's really challenging, like what the case Lucy showed, you know. So, you know, and there are, you know, vendors out there in terms of doing virtual TE from 4D CT data set to kind of predict whether or not you need extra additional advanced imaging modalities. And in addition, this tool can be used for education as well and teaching for your fellows or other, you know, faculty as well in terms of TE imaging. So certainly something to look forward to, you know, in advance in terms of predicting, you know, TE, how hard it can be on the table rather than just guessing while going in. So I always like my old fashioned, I think, as my mentor taught me back in those days, going back to the basics, think outside the box, you know, I think use all tools, the beauty about that, not the old fashioned, but the new tools that we love all the time, 2D, 3D MPR. And then the most important thing, I think, as us imagers, understanding the limitations of 3D MPR. If we can't get it, revert back to 2D and then go back in again. Always, you know, do what's best as long as you see it. And, you know, we are lucky. I think we got advanced imaging modalities like 3D eyes, 4D eyes, certainly exciting times. I think with the virtual TE too, exciting times to be in the structural interventional echocardiography field. So with that, thank you very much.
That was fantastic, Nadira. So I actually did not know you were going to show that case, and now I remember it. So, and you know, a couple of things I would like to say is that, you know, the imager who started that case, you know, had the humility to call for help, and I think by doing so, I think that imager learned, and we all learned, because you came in and you saved a case that I was just about to abort. And the amazing thing is, well, those transgastric images were just beautiful. I mean, we
lucky.
we looked at it and it just fell into place, and literally I think we were done like 15 minutes later, and it was just beautiful. So don't forget about the transgastric. You showed going backward, but you also showed going forward. ICE and the virtual TE by CT, amazing stuff. I think what Joao is working on there is just out of this world, among others, and it's more to come. Abdullah, Lucy, thoughts from your end? Oh, sorry, Lucy, you're on mute.
As an imager, I have extreme respect for, you called it an old fashioned, but I mean, that's extremely, I think, advanced. You used all the new technology out there with the NPR and thinking outside of the box. And I think as a structural imager, you need that. I think you have to think and my mentor used to say, nobody likes a quitter, right? So when a patient's there and they're on the table, they're intubated, you got to think outside the box to really see what you can do to help the patient. So congratulations on your case.
Thank you.
Abdullah?
Same. Incredible case. And Nadira, I'm not surprised you saved the day again. So the images were really challenging, but the transgastric were awesome. So congratulations.
Yeah. I think I'm going to start looking at transgastric a little bit more for Mitchell. It's fantastic. Well, we're at the end of the hour. I'm going to save my case for the next webinar. So sorry for those of you who only came on because of my tweet. You're just going to have to wait. We'll have another one in about a month, and I'll show my case then. But I really want to thank all of you for participating tonight. I love these webinars, and I always learn so much, and you guys are amazing faculty. So on behalf of CVI and all of you, thank you to all the attendees who participated tonight, and we look forward to seeing you again. Thank you so much.
I'm going to stay on for a minute. I'm going to put the slide back up with the link and information for people if they want to grab that. But you guys can log off. Thank you so much, everyone.
Thank you.
And the video will be added to our website and our YouTube channel in the next day or so.
Awesome. Thank you so much.
Perfect.
Thank you
so much,
Take
everyone.
care.
Have a
Great
good night.
case,
Oh, Dr.
everyone.
Goswami wants to know, is that your favorite cocktail? In the chat.
Oh, who's that? Who said that?
Neil Goswami.
Oh.
Of course it is. You need the sweetener. All right. Bye, everyone. Thanks so much.
Bye. Good night.
Bye,
Thank you.
everyone. Have a good night.